everyone, and welcome to Wellness Matters, brought to you by the American Hospital in Dubai. As always, we strive to give you a comprehensive look at a number of wellness and health-related issues every week, and welcome your questions in the live chat on Facebook, YouTube, and Instagram, so don't be shy. We've all heard of radiation therapy or radiotherapy, which is usually used in the treatment of cancer. But how does it work? At high doses, radiation kills the cancer cells by damaging their DNA. The damaged cells are later broken down and excreted by the body. Of course, there are several types of radiation therapies, and they depend on the type of tumor and location of the cancer. Dr. Tarek Dufan, who is the Chief Medical Officer here at the American Hospital, has over 20 years of experience as a radiation oncologist and will help us understand the latest radiation treatments tonight. Dr. Dufan, welcome to the show. Let's tell the viewers a little bit more about you. So you have practiced and taught at some of the world's most prestigious medical organizations, and you hold certifications from American and Canadian medical authorities. You're also a fellow associate of the Royal College of Physicians and Surgeons of Canada, Radiation Oncology and Cancer Care at the University of Manitoba, and you also hold a master's degree in anatomy and cell biology from Richmond University in London. I look forward to tonight's episode, so let's start with the 10 quick questions.
Okay.
Modern radiation therapies allow for better localized treatment of the cancer without affecting the healthy tissue surrounding the cancer. So is this an accurate statement?
It is. It is very accurate statement.
What are the three main risks associated with radiotherapies in a few words?
Well, there is three common scenario, which is the skin reactions, tiredness and fatigue in general, and a side effect specifically for the location.
Myth or fact? Radiotherapies are painless.
Which is true.
Myth or fact? Radiotherapies make the patient radioactive.
Well, it depends on the type of the radiations.
Radiotherapy leads to hair loss. Is this true or false?
If we treat the skull, yes.
Myth or fact? Radiation therapy mutates the genes, and this can be passed on to children.
If you treat a sensitive area related to that area.
Radiation therapy increases the chances of developing more cancer in the future. Is this a myth or a fact?
It is a fact, but it takes a long time, 20 to 30 years.
Radiation compromises a patient's immune system. True or false?
Usually, in most of the scenario, not.
A patient can continue to exercise during treatment.
They need to live normally, and it will not affect daily activity.
Let's end with a few words of wisdom for your patients undergoing radiotherapy.
Radiotherapy is a daily treatment, so it will become like a routine, but that doesn't mean that it will affect your other normal life activities. So it should be continuous life activity, but the radiotherapy is part of it.
Doctor, let's begin by highlighting the importance of early diagnosis when it comes to cancer treatments.
This is very important subject, and it is a worldwide. Early detections, it's now a major role in treating cancer. It's including mainly the 2 to 3 major cancer, like a breast cancer with the mammogram, like a prostate cancer with the PSA. It will affect the outcome of the patient and what kind of treatment you receive. Sometimes when we discover the cancer is late, that means the patient will go through longer treatment, more side effect, and the outcome it will not be favorable as an early treatment. In terms of the economy and the country, early detections, it will be much easier on the economy and the cost in the country in general.
Now today we are going to discuss a number of radiation therapies. Let's begin with Stereotactic radiosurgery, or SRS, which was pioneered around 50 years ago as a less invasive and safer alternative to brain surgery to treat several diseases and disorders, not only cancer. But first, let's explain how this technology works.
See, stereotactic radiosurgery, it's exactly in a small word, is doing surgery without opening the patient's skin, without opening the patient's scalp. It's discovered initially in Germany, and it's mainly by neurosurgeon who did not able to get into a very deeper structure in the body. So what he did, he delivered a very high precise dose of radiation by using multiple beam to do the same outcome with less side effect, less toxicity as surgery.
And this is, I think, the machine which has this treatment, which gives this treatment.
It's true. This is the machine, the LINAC-based machine that we have at the American Hospital. If you see on the bed, that's the frame that we put on the patient to make sure the mobility is limited, because we are using a very high dose of radiation.
Now, it's very interesting that this type of treatment can also be used for Parkinson's disease, for other tumors which are benign, such as acoustic neuroma, in addition to cancer. So I found that very interesting.
True. We all think that radiation treatment is mainly for cancer-related disease. The reality, there is many neurofunctional disease that can be treated or can be improved by using radiation. For example, in the Parkinson, they use it to interfere with the neurosignal, that it will decrease the intentional tremor that the patient have, and that it will help improve his quality of life and make him more functioning daily to daily basis. In terms of the acoustic neuroma, we see it mainly by a small tumor that's sitting on the top of the nerve that's controlling the hearing, and it's very close to a very sensitive area. So when we do the treatment, which is to take maybe less than 5 minutes, in the past we use a very complicated surgery at the base of the skull, which take at least 6 to 8 hours operation, with staying in the ICU, staying in the hospital for a long time.
SRS, going back to the treatment used for cancer patients, it's usually used for areas that are very sensitive, particularly the brain.
Yes.
So can you explain how many sessions a patient would usually need? How is the assessment done? And how will the radiation be targeted so that it will not affect healthy tissue surrounding the tumor?
You see, treating the brain is very crucial, because the SRS, the stereotactic radiosurgery, they use it mainly when we have a limited number of disease, limited number of tumor in the brain. And at that time, many studies show that if you use an aggressive stereotactic treatment, it will improve their outcome. The problem with that, we cannot go with a higher dose of radiation, because if you do that, it will damage the surrounding structure. So the process starting by something called the CT simulation, which is exactly like a measurement session for the patient, creating a mask, creating the skin, and the teeth fold, creating the nose stopper, and all of those, they will limit the patient mobility, the brain mobility or the head mobility, within less than 2 millimeters, which is very, very tight. And when you use multiple beam of radiation by different arc, which is swinging, if you see the machine, the machine have 4 arms that's swinging around the brain, which is like the patient here is in that mask, and it will be intersect in the point of radiation. So they will deliver a very high dose of radiation in a very small area with a rapid drop-off, which is the fancy meaning of saving the surrounding structure.
Now, how do you assess how many sessions a patient would need?
Yeah, so it's depend on the number of the lesions and depend on the size of the tumor itself, or of the lump in the brain. If it is a smaller tumor and it is in a safer place, usually we use a high dose in one treatment and it is done. But if it is closer to a critical structure, then you need to take it easy on the critical structures to make sure you don't give him a lot of side effects. So you do something called fractionation, which is dividing the dose of radiation in many days.
Now, the same technique can also be used on various parts of the body. In that case, it's called SBRT.
You're right.
Which cancers is this treatment most effective for?
It's the same principle. They're using the SRS, we're using the SBRT, which is building a mold around it. But the most common scenario we use it when it is in the lung lesion is multiple metastatic disease or spreading small spot in the brain, like in this scenario here with the LINAC-based SBRT. This is kind of the setup or the mask that we use around the patients, or we use it closer to the spinal cord, we use it closer to the kidneys, and also in the liver and any other areas sensitive.
Now, are there any side effects associated with stereotactic radiosurgery, whether on the brain or the body?
It is, because you need to have a significant and a good team around you to deliver this kind of radiations, because it's a very high dose of radiations. For example, if we see the treatment of SBRT to the lung, which is treating a small spot in the lung, if it is closer to the ribs and you are not careful, you may cut the ribs in through and through if you deliver the dose of radiation. So it's very, you need to be very accurate to avoid those structures. But in general, you will have a little bit of tiredness, fatigue, some dry cough because of the scarring, but usually they recover within a few months.
Now, another therapy is brachytherapy or internal radiation, and this allows the doctor to actually put the radiation inside the patient's body.
It's true.
So let's start by explaining how it works.
It is the principle of radiation. Brachytherapy, it is the best scenario you can deliver radiation to any patients. Why? Because the principle of radiation, you deliver a very high dose of radiation to the brain or to the tumor, but you're saving the surrounding tissue. And the only way to do that, the max, is by putting the radiation inside the cancer. And that's exactly the brachytherapy. For you see, this is the brachytherapy room we have in the American hospital, which is very unique. So this is the operation, it's an operating room. So if you see, the bed is set up mainly for gynecological female kind of cancer. The small machine that's sitting in front of the bed, it's actually the Versaseed, which is the machine that's holding the seed of radiation, which is usually a very tiny seed, like a rice seed. And the room in the back is actually the shielding room that holds the machine. So brachytherapy is delivering a small, tiny seed of radiation inside the tumor. It will deliver a very high dose of radiation, but with almost zero doses to the surrounding normal structure.
So is it usually mostly used for female-related cancers, or what type of cancers is it mostly used for?
That's a very good question. Certain cancer, they need a high dose of radiation to control them or to get rid of them. And those certain cancer, you cannot deliver the radiation, all of it from outside, because when you go from outside radiation, that means you need to go through normal tissue and you cause a lot of side effect. So what we do part of it from outside and the rest is putting the radiation inside the tumor. And specifically, which more common, we see it in the gynecological cancer, which is uterus or cervix. In the male, you have it in the prostate cancer. But sometimes, because of the principle of radiation, if you have somebody that had been treated before and you try to treat it again, your concern is the surrounding tissue, normal tissue structures, and the side effect. So your best option is to put the radiation inside the cancer and avoid the surrounding structure, which is what we do in the head and neck cancer, which has been treated before.
Now I have to ask, how do you insert the radiation into the body?
It is an interesting procedure. So there is 3 options. One option is by sticking a needle that carrying the seed of radiation inside the organ, and then you drop them one by one, and that's in prostate cancer. The other option is to use certain device that it will be sitting beside the tumor, and it will use that device as a channel to bring the seed closer to the tumor, which is in case of the female cancer. The other option is to stick a needle inside the tumor, and that is to create a line that going through the cancer, which is mainly in the lung, bronchial, when you have a bronchial obstruction. And we did the case here in the American hospital.
This is probably a procedure that takes more than 5 minutes by what you're describing compared to the SRS and SBRT. So right. What can the patient expect when undergoing such a treatment?
See, that's a very good question, because it's something different and unique than the regular treatments. So there is 2 options for it. One option that you can do it without anesthesia, and that's usually shorter. But the one that takes the most is the one that is taking anesthesia. It's an operating procedure. So patient will come fasting, the anesthesiologist will be in the room, they will do the anesthesia, patient will be sleeping, will do a CT scan while sleeping, do the measurement, put the device in, plan the treatments, then they give the treatments. This procedure from in and out takes between 2 to 3 hours.
It's also, in this kind of treatment, there are 2 types of treatment. There's the low dose and the high dose treatments. So can you explain the difference and which ones can be done completely outpatient, which ones would require inpatient?
That's a very good question. Very good questions. It's depend on the dose rate that come from. What to mean by dose rate is depend how much that seed of radiation will release the radiation out. The slower the radiation come out from that seed, the longer the treatment, and the patient need to stay in the hospital. And that's the LDR, which is the low dose radiotherapy. The one with the high dose, it is a high dose by the name. So they deliver the dose very quickly. So your procedure, you put the seed in and you need to take it out quickly because they will deliver the dose in a short time. So HDR, usually it's an outpatient procedure. LDR, usually patients stay, when I was in US, we do it like for almost a week. Patient, mainly in the breast cancer, the needle will be sticking in the breast for almost 3-4 days. And every day I come and I give the session of radiations.
Is this where the patient might be radioactive?
That's a very good question. Usually the radioactivity come when they go home with the seed or with the radiation seed. Any place or any kind of brachytherapy that we take the seed out, take the active source of radiation out, then we don't need to be worried about the radiation seed. Usually patient go back home with the seed of radiation or the source of radiation in prostate cancers, or in sometimes when we give it for the thyroid cancers. So those are the scenario when the patient still have some radioactivity, and the main reason we need to be careful with that person because the radioactivity, it will be affecting the surrounding mainly families.
Mm-hmm.
Yeah.
So what kind of precautions should he take?
Usually it's like a quarantine kind of a scenario. So starting from visiting the bathroom, so he need to have his own bathroom or her own bathroom for the few days. Usually even flushing, it need to be careful. And the towels and everything need to be separate. The washing machine, it need to be washed separately. And if you wanted to have one washing machine, so you need to wash your clothes. Then after that, you wash empty. Then you use it for the family. The food is the same, and usually you don't leave the room in certain time until the activity drop at certain level to be safe going around.
So how do you know when you're not radioactive
Yeah, that's a good
anymore?
question too. So for example, for the seed of radiations, those are for the prostate cancer, for example. Usually we keep them a day or two in the hospital, then they go out, and then we ask them to not have, for example, if he's a father or a grandfather, don't play or don't bring your grandkids closer to your lab because that area is sensitive. Mm-hmm. If somebody having a thyroid cancer treatment, usually we keep them isolated, quarantine. For example, we're unique here in the American hospital. We have one of those ablation, call it ablation therapy unit. So the patient will stay in the hospital for 2-3 days. Then the physicist will come in and he will check how much dose of radiation coming out from him. And he need to have a certain safe level of radiation coming out to let him go out.
So now, how much social distancing then he should keep with
others?
It's
more than the COVID. I can guarantee you more than the COVID.
I think we're used to social distancing and quarantining now with COVID.
Yeah.
But so the terms are very familiar, I think, to everyone.
Yes.
And even the treatments you mentioned, I mean, even the precautions you should take at home are sort of a bit similar to COVID patients.
It's more than that.
More than that, obviously.
More than that.
But,
for example, if going out to home with a certain level of radioactivities, he need to kick out everybody from home. He need to stay alone for at least in his room and the bathroom and the kitchen, because those are the common area that he will use. The second one, if he is radioactive material because of the prostate cancer treatments, then it's at least 2 to 3 feet to make sure that you don't come in certain area here to be in the safe side.
One more treatment is IMRT,
yes,
which is the intense modulated radiation therapy.
Yes.
And this is quite interesting because it allows the dose of radiation to conform to the shape of the tumor. So can you explain it?
This is one of the most important technology or advance happen in radiotherapy era. In the past, the radiotherapy is started very primitive. We start with 2D, 3D. Then this is exactly when you go to the movies now. You have the 2D, the 3D, then you have the 7D. It's exactly the same. So this is one of them. This is the machine we use in the American hospital. So the 2D is actually using 2 beam of radiation. So if you wanted to treat a certain area, you need to treat a bigger area, and you cause a lot of side effect just to target that area. But we're using 7 beam. For example, if you see here, this is the head of the radiation machine. So the radiation, it will be split into beamlet, which is a small beam of radiation, and usually 7 to 9 to 11 beam. And it's like 70, 90, and the radiation field of radiation, or the dose of radiation, will be very conformal to the tumor, and it will be very rapid drop off. Means that the radiation, it will be drop off quickly, no dropping dose of radiation around the normal tissue, and dropping all the dose of radiation only in the tumor. And this is make a big difference by 2 ways. One, it make it very safe to treat many patients because the side effect is less. And the second component, there is many cancer we were unable to do anything for it before because we cannot reach to a certain dose of radiation because of the side effect. But now, because of this technology, we can go for 7 weeks of radiation instead of 6 weeks of radiation, and it make a big difference in terms of cancer control, like in the head and neck cancer.
So which cancers is it used for mostly?
It's used with everything, but it's mainly is the head and neck cancer, the brain cancer, and the prostate cancer.
Looking at all those different radiation therapies, let's talk a little bit about success rates.
Good.
So which ones have the highest success rate, or are they all similar? Can you just talk us through the different success rates, and does it depend on the kind of cancer you have or location of the cancer when it comes to the success rate?
This is an excellent treatment. So there is many factors in this. First of all, in this room, we use it for the tumor board. So if you ask my colleagues, the medical oncologist or the surgeon, we always have this fight. My treatment is better than your treatments. I will do the same job. I'll do the same outcome. But the reality is depend on the type of cancer and the stage of cancer. Some certain cancer, radiation, it will not work at all. So we don't use it at all. And some certain cancer, surgery is the way to go. And some certain cancer, surgery is out. And some certain cancer is the chemo is the way to go. For example, in breast cancer, which is the most common, if it is too early or so early, stage 1 disease, and you use certain surgery, that's it. Surgery is enough. You may not need a little bit of hormone, but you're fine. If you go to a little bit of higher stage 2, late stage 2 or stage 3, then you need to have chemotherapy, you need to have radiation, and even with all of that, is still the outcome is not as stage 1 or stage 2. But if you wanted to compare apple to apple, if you treat prostate cancer with surgery or with radiations, the outcome is the same. This is why they call them option. But people like surgery, one-time deal, do surgery. I don't like the cancer to be in my body. I need it out. That's the way to go. But there is some different side effect of that. On the other hand, you have the radiation. You need to come to the hospital for 7 weeks daily, for 5 days a week, for a few minutes. That's also kind of a routine. So it is a lifestyle, which one you want, but the outcome is the same. The same thing in the lung cancer. If it is early stage, you start thinking about surgery, SBRT. So it depends on the stage and the type of cancer.
And when it comes to side effects of radiation long term, what are the main ones someone should be worried about?
Well, that's a very good question. So radiation is not easy on the body. That's completely understandable. And it's depend on the stage of the patient. It depends on the age of the patient. Right now, we are the only hospital that treat pediatric cancer with radiation treatments. Those patients, you need to be very careful for them because they are growing. So you'll have some growth effect by the radiation, mainly if we treat certain area of the body, like the spinal cord. So long-term side effect in kids treatments, it may cause delay of growth of certain area in the bodies. If you come to the long-term side effect of treating radiation in adult, it's mainly either the dysfunction of that organ. For example, if we treat the head and neck area, sometimes the swallowing will be affected because of the stiffness, because of the radiation. If we treat the breast, for example, this 20 years down the road, 30 years down the road, there is a very small risk. It may devolve a skin cancer because of the radiation, because radiation is some kind of sun. So it's like a sun exposure.
What about the effects on fertility?
That's an excellent question. It also depends on 2 factors. If it is a male or female. The female are very sensitive. The ovary are very sensitive to radiation. So we need to be not a social distance. We need to be far away from the ovary to make sure that will not affect. It will shut down with a very minimum dose of radiation. So if you treat the abdomen or the pelvis, the ovary will be done. So sometimes we end it by, if the patients want still to have fertility, to do surgery to move the ovary above the abdomen, avoiding touching them with the radiation. So they are sensitive if they are in the field of radiation. If they are outside of the field of radiation, the dose is reasonable, you can control it. The same thing with men. If you are closer to the sensitive area, then yes, it will be affected.
But in case you undergo radiation and you move the ovaries to a certain extent,
yes.
Is it still safe to have kids in the future?
Wallahi, this is very smart questions. Yes, it is safe, but you need to delay the conceiving time. Usually the recommendation, you need to wait for at least 6 months before you'll have baby after you get the radiation. And the reason for that, there is something called scatter radiations, which is the radiation that kind of go left or right in the body. And because of the ovary very sensitive, the ova very sensitive, when it gets hit with the radiation, sometimes it will cause genetic deformity. So we get nervous because there is some chance of having deformity in the baby. 6 months, then it's safe to go.
Really, really safe?
Yes, safe to go. Why is that? Because usually you wait for 3-4 cycles of ovulations until the effective radiation wash out from there.
And what about men?
It's the same story.
Same story.
These are two areas very sensitive.
And will it affect fertility in kids if a kid is having radiation
Which is
therapy?
Completely 100% it will affect. Unfortunately, yes.
To what extent? Do you have any idea?
It is the problem with kids. Most of their tumor, they come in the abdomen or in the brain. That's what we see most, or in the spine. And the baby is small. Sometimes we treat as low as at 14 months here in the American hospital. And we treat as, like on every week we have 1 or 2 patients of those pediatric cases. Unfortunately, baby is small. So when you try to treat a tumor that's like 6 centimeters in the abdomen, by default, the abdomen is not that big. By default, you'll have some effect on the ovary. And unfortunately, yes, it will have some effect. It will have.
This is very sad.
I agree. I agree. It's a tough one.
It's really tough. I'm sure it's tough for you to see those patients as well.
It is very tough one. And I'll be honest with you, this is a teamwork. For example, when we have kids, right now we have kids in the on treatment. Usually we don't take more than one because it needs a lot of attention. And the problem with treating kids, actually you need to put them in sleep every day for sometimes a month and a half, just to make sure they will not move. Because if you put them on the table, he will jump down.
Yes.
So you need to be careful with that. And the team, I really happy that we have this team in the American hospital. The team, they will create a schedule for the baby that have a Cinderella or have a Smurf or something. So every bit that day she will come and she will be so eager to check out the number of sessions that she had. And then she will look for the stickers. It's funny now, we have one of the patient now, the patient we have right now, she was very grumpy with me in the first week. She don't want to even to talk to me. And the reason for that, because I'm not wearing something pink when I come and treat her. So she forced everybody to wear something pink. And when she come, we wear, I don't know what they call it, just a scarf, just a pink scarf for everybody to see and to feel comfortable. Then after she leave, we put it back on the side. So,
well, that's very nice of you to do. And it's good that kids are usually quite resilient and they adjust to their situations. But really, I hope that God gives strength to their parents and to those kids, because it's really hard to undergo such a treatment at such a young age. Dr. Dufan, thank you so much for clarifying a lot of the radiation treatments available. And if you are struggling with cancer, I hope that we clarified a lot of things related to radiation and radiotherapies tonight. And surround yourself with people who will love you and support you without judgment. And to all our viewers, I would like to say thank you for joining us for 12 amazing episodes of Wellness Matters. Tonight we end season 1. But we also promise you that we're coming back with a better and more exciting season 2. So look out for the details on the American Hospital's social media pages. I will see you soon, and have a good night.